The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/GKC860. Downloadable slides and practice aids are also available.
Hello, and welcome to Preparing for the Next Leap Forward in Multimodal Management of Esophageal or Gastroesophageal Junction Cancer, an interdisciplinary tumor board on adjuvant immunotherapy. My name is Dr. Ronan Kelly. I'm the Chief of Oncology at Baylor University Medical Center in Dallas, Texas. And I'm joined today by my colleagues, Dr. Yelena Janjigian from Memorial Sloan Kettering and Dr. Russell Hales from Johns Hopkins University. Thank you both for being here.
Great to be here.
It's a pleasure. Thank you.
Esophageal cancer is the sixth most common cause of cancer-related death worldwide. In the United States this year, 18,000 new cases will be diagnosed, and unfortunately, 16,000 deaths will be expected. We see a 2.4-fold higher incidence rate in men than in women, and the 5-year survival rate still remains poor at 12 to 20%. Poor outcomes are due because patients often present with advanced disease, but also because the biology is challenging in this disease. And cancers of the lower part of the esophagus and gastroesophageal junction tend to have resistance to systemic therapies as a result of histologic, molecular, and etiologic heterogeneity. Thankfully, we do see improved outcomes in patients with early stage disease, and today we'll be talking about some potential practice-changing trial in the adjuvant space. Trimodality approaches involving neoadjuvant chemoradiation followed by esophagectomy, or perioperative chemotherapy with some cycles before and some cycles after surgery, are widely used treatment regimens based on physician preference and access to radiation. In the United States, chemoradiation followed by surgery, so-called trimodality therapy, remains the preferred treatment approach. If you choose perioperative chemotherapy, very often the FLOT regimen is a preferred treatment regimen in the year 2020. Increasing data shows that immunotherapy has a role in esophageal cancer, and we've seen some practice-changing data presented at this year's ESMO Presidential Conference, which my colleague Dr. Janjigian will present. But we've also seen for the first time data in the adjuvant setting, which I will present for Checkmate 577. So that's the goal of this activity. We want to prepare yourself with some practice-changing data in not only the advanced setting, but also in the early stage disease setting. Today's program features great faculty. Dr. Yelena Janjigian from Memorial Sloan Kettering will review the pivotal trial evidence from two very important studies that were presented at ESMO, Checkmate 649 and Keynote 590. I will present Checkmate 577 on the role of adjuvant nivolumab in early stage disease. And lastly, Dr. Russell Hales, who's our thoracic radiation oncology expert, will lead us through some patient cases to understand the future implications of immunotherapy in early stage esophageal cancer. So let's get started. If we look at the current role of checkpoint inhibitors in gastroesophageal cancers, you can see here the different FDA-approved indications. Pembrolizumab is approved in gastric cancer in the third-line setting, in those patients that CPS greater than or equal to 1, and in nivolumab is approved in Japan. In esophageal cancer, we've seen recent approvals in the second-line esophageal squamous cell carcinoma population of patients, with both pembrolizumab and nivolumab approved. And we also have a tumor-agnostic indication for pembrolizumab in those patients that have mismatch repair deficiency or microsatellite instability high tumors. We're now going to look at all the pivotal trials that we think will change the field for esophageal and gastroesophageal junction cancers. As I said, we'll move from metastatic disease to early stage disease. I'd now like to introduce Dr. Yelena Janjigian. who is the chief of the Gastrointestinal Oncology Service at Memorial Sloan Kettering, who will demonstrate some of the data from practice-changing studies that were presented at ESMO in 2020.
Thank you for this kind introduction and for the opportunity to review this data with our radiation oncology colleagues. And it's important for all of us in oncology to be aware of this emerging transformative data as we treat our patients in the disease management teams. As you heard nicely summarized by Dr. Kelly, the treatment paradigm for immunotherapy and the place of immune checkpoint inhibitors in metastatic esophagogastric cancer have evolved substantially. And ESMO 2020 was a historic moment for our upper GI malignancies. The current paradigm for first-line treatment, however, pending any practice-changing approval, is that chemotherapy with FOLFOX is used commonly for adenocarcinoma in first-line setting. Addition of third drug cytotoxic chemotherapy is reserved for only select fit patients that are symptomatic and have large disease burden. Patients should be routinely tested for tumor HER2 expression, and trastuzumab is added in patients with adenocarcinoma. And the newcomer is CheckMate 649 data that we will review for combination of 5-FU, oxaliplatin, and nivolumab, and Keynote 590 data, which applies more to esophageal and squamous cell and adenocarcinoma, looking at first-line chemotherapy plus immunotherapy. In second-line treatment, once again, right now, the immune checkpoint inhibitors are used mostly for high PD-L1 expressing tumors. And although there is an indication for nivolumab irrespective of PD-L1 status, most of us agree that even in squamous cell cancer, the responses are limited, and therefore we really, in practice, reserve it mostly for squamous cell with high PD-L1 expressing, generally with a cutoff of CPS greater than 10. In third line, pembrolizumab is commonly used in adenocarcinoma, but once again, for CPS greater than 1 category, although there is an indication, and we'll review the data, the responses are not as dramatic as you would see in later with higher PD-L1 expression. So the benefit there is really dependent on level of PD-L1 expression. The way we think about PD-L1 in gastric cancer is important distinction from lung cancer. We look at both tumor and stromal expression, and we look at the combined positivity score or CPS score. So if you see in your pathology report of a patient, you're seeing a tumor staining is involved, or TPS for esophageal and gastric cancer, that's not the correct way to look at it, and please ask your pathologist to restain the tissue or to re-review it with CPS in mind. Keynote 59, it was a single-arm study that really put pembrolizumab on the map in third-line setting in particular. This was a study in third line and beyond in metastatic disease, and patients were enrolled irrespective of PD-L1 status. And as you can see here, the majority of the benefit, or the higher response rate, 23% overall response rate, was seen in third-line patients for CPS greater than 1 cutoff. So that was what was granted the conditional FDA approval for pembrolizumab, and based also on promising survival data. But this data will need to be confirmed in larger studies if the conditional approval remains to be had. Well, so other studies that also validated this approach in metastatic disease included several studies in later lines of therapy that are summarized here, and also studies that are ongoing. Unfortunately, what we do see is that maintenance therapy or maintenance of avelumab, as was discussed and published for Javelin studies, in other words, switching after a certain number of cycles of chemotherapy, switching to maintenance anti-PD-1 or anti-PD-L1 blockade is not going to be an effective strategy, at least not yet proven in our setting. And we will now discuss the promising first-line study, the CheckMate 649 data, And as you can see here, the next possibly practice-changing study that we'll be reading out soon is the KEYNOTE-811, which is a study looking at HER2 plus anti-PD-1 inhibition in first-line setting for HER2-positive patients, which is also potentially exciting based on the initial phase 2 data that we've seen. So without further ado, let's look at the CheckMate 649 data. And to give you a background on this, last year and within a year or so, we looked at KEYNOTE-62 data, which was a first-line pembrolizumab trial. It was a smaller study, not as clearly designed, and everyone was heartbroken because the study was essentially a negative trial. So the excitement around CheckMate 649 data, and this is a trial that was initially designed to compare a combination of anti-PD-1 plus anti-CTLA-4 blockade with chemotherapy. Subsequently, at a later date, FOLFOX nivolumab arm was added. So this is a standard approach with FOLFOX or CAPOX versus CAPOX or FOLFOX plus nivolumab, and at ESMO 2020, this combination was compared. It's important to note that both esophageal and GE junction and gastric adenocarcinoma patients were enrolled. So this is adenocarcinoma only study, enrolling patients all over the world, irrespective of PD-L1 status, and patients were either HER2 negative or HER2 unknown status. And these are the exciting Kaplan-Meier curves for primary endpoint of overall survival, and it was powered for CPS greater than or equal to 5 category. As you remember earlier, the indication for Pembro is CPS greater than 1. Here it's even a higher selection of CPS greater than 5 category. Although overall survival was compared in all groups, the primary endpoint of overall survival in CPS greater than 5 category was clearly most clinically and statistically meaningful, with over 3 months benefit of 14.4 months in the median overall survival in the experimental arm, compared favorably to 11.1. This is a benchmark and a cornerstone of advancement in gastric cancer. We finally cleared 1 year median overall survival in an experimental arm in HER2 negative study. So really exciting. And as you can see here, the Kaplan-Meier curves cross and show benefit for nivolumab plus chemotherapy. At the very beginning, there's no crossing of the curves at all. They clearly separate all along. And excitingly, at 12 months, 57% of patients were surviving on the experimental arm. So really clinically meaningful. What's also interesting, in other subgroups for CPS greater than 1 or all randomized population, the hazard ratio was still very promising, with hazard ratio of 0.77. The median overall survival in CPS greater than 1 category in this cohort was 14 months, which is also very nice. And as you can see here, even in all comers, all randomized patients, the difference was clinically and you would argue statistically significant. Whether or not this will be enough for the regulatory authorities to approve nivolumab irrespective of PD-L1 status is not yet known, but nonetheless, this is promising data and will change practice for our patients. These are the subgroups of patients. It appears to be that MSI status obviously is important, and the hazard ratio for those patients is 0.33. So please, for those of you who are out in the practice, make sure your patients get MSI testing done as early as possible, even in early stage tumors. This is quite meaningful and important. And as I mentioned, both esophageal GE junction tumors also appear to be benefiting, although it appears to be that the gastric cancer benefit is the most pronounced. And what's interesting about the study, a majority of the patients in Asia were actually enrolled outside of Japan and China. And that may be also important to see, as that population of patients in their outcomes mirror more of the rest of the world than Japan. Again, highlighting the importance of MSI testing, this is data from KEYNOTE-62 data, which I mentioned to you, it was negative overall in first-line setting with pembrolizumab versus chemotherapy, unless you were MSI high, and this is exploratory subgroup analysis, the hazard ratio was 0.29, and very exciting, and the best curves that we've seen ever in this disease. So with this data, promising data, what we're doing is actually using circulating tumor DNA to select for patients who have finished chemotherapy, radiation, and then surgery. And if they're MSI high, irrespective of tumor histology, then and they're genotyped and tested for circulating tumor DNA, and if they're ctDNA positive, they go on to receive pembrolizumab. So this is a study I have open at MSKCC. It's a small study, so please reach out to me if you have a patient and if you're interested. We can discuss this approach. Well, what about squamous cell cancer in first-line setting? So Keynote 590 was mostly an esophageal cancer study, exclusively esophageal, looking both at squamous cell and adenohistology. I have to say that I think these type of trials are going to be less frequent. The future design, as Dr. Kelly mentioned, we like to understand the biology of the disease, and the adenocarcinoma of the esophagus is really biologically similar to the GE junction and proximal gastric adenocarcinomas. And so squamous cell cancers behave very differently. Nonetheless, in this study, patients were randomized in 1-to-1 fashion to receive 5-FU cisplatin, which is relatively outdated, more toxic regimen at 80 milligrams per meter squared of cisplatin. Oxaliplatin is much better tolerated. And then here we have patients who received both with pembrolizumab or without. The majority of the patients were esophageal squamous cell cancer patients, and that population likely drives the overall survival benefits seen on the study. And as you can see here, the Kaplan-Meier curves are very nice and exciting. And again, neither on Keynote 590 nor Checkmate 649 there were any new toxicity signals. This was an expected and relatively well-tolerated regimen. Hazard ratio in in Keynote 590 was 0.73 in all patients. And as you can see here, for CPS greater than 10 category for squamous cell cancers, the hazard ratio is 0.57. That's very exciting. And it again highlights the importance of PD-L1 testing and initiation of anti-PD-1 therapy early in those patients. And for all-comers CPS 10, the hazard ratio is also very nice, 0.62. And overall, it seems like for adenocarcinoma, again, if high PD-L1 expressing, perhaps those patients benefit as well. Whether or not this practice will change for esophageal adenocarcinomas that are less than CPS 10 is to be determined. But overall, this is a confirmatory study and companion with Checkmate 649 showing that immune checkpoint inhibitors in first-line setting are helpful and will change survival for our patients. And both for adenocarcinoma and squamous cell cancers should be considered for metastatic disease. I think it's exciting data, and the field of immune checkpoint inhibitors evolving rapidly. Whether or not the new adjuvant approaches in both early and advanced stage esophagus and gastric cancers will come to clinic soon in combination with immune checkpoint inhibitors, that is to be determined, but that certainly is the future strategy as these regimens appear to be well tolerated and really meaningfully impact survival of our patients. Thank you.
Thank you very much, Yelena. And, I just want to emphasize the historic nature of the ESMO plenary session where we had 4 esophagogastric presentations. It's never happened before. We may not ever see it again, but the take-home message is immune checkpoint inhibition in esophagogastric cancer has arrived in 2020. It's very likely all patients with metastatic disease will receive a checkpoint inhibitor combined with chemotherapy now moving forward in the future. We will talk about the potential practice-changing data in the adjuvant setting in the next section. But we have a couple of questions coming in, Yelena, and maybe I might ask you these. So some of the questions are in terms of, is there a difference in activity between pembrolizumab and nivolumab? And is it really necessary to check PD-L1 expression?
That's a great question. And I believe anti-PD-1 agents are all created equal, and there's no difference in the activity between nivolumab and pembrolizumab. Certainly the dosing schedule and the backbone of chemotherapy will come into play. Most oncologists are very comfortable with using FOLFOX. And again, in some of our older, frailer patients, every 3-week dosing with oxaliplatin can be quite challenging, and certainly cisplatin is not used at all. And so clinically, there's no activity difference, but logistically, just based on the data and which chemotherapy backbone to use it with, it may be that because of FOLFOX use is so prevalent that nivolumab will be easier to use in the clinic. In terms of PD-L1 testing, there's so many challenges and technical challenges and interpretation challenges with the CPS score, particularly with several different antibodies that are approved and are used in standard setting. And also, since most of our oncologists and pathology labs in the US are used to dealing with lung cancer, again, the challenge there is which antibody to use and what is the accuracy and the reproducibility of the testing. I think nonetheless, and all of these challenges are certainly solvable, and we need to continue to work. Just because something is difficult to do doesn't mean that it's not worth doing. And so we need to continue to test for PD-L1 testing status, as it will help us sequence the regimens and know in which patients the risk of additional therapy with anti-PD-1 therapy is warranted. Because even though the toxicity profile is manageable, it does come with certain risks.
One other quick question. Did we see any difference in toxicity in esophageal gastric cancers than we've seen in other tumor types? Many of our radiation oncologists will probably be familiar with their colleagues giving these in lung cancer. Did we see any new safety signals emerging?
Not at all. I would say looking at the data, perhaps with combination of oxaliplatin, you see a little bit more, it can be a little bit more challenging to decipher the mild LFT abnormalities that you see sometimes with oxaliplatin. Is it related to oxaliplatin or nivolumab? In our clinical experience, the nivolumab-related AST/ALT changes are quite more dramatic and durable. And in other words, they don't fluctuate if you hold, for example, one of the agents. So with clinical practice, they're becoming more and more straightforward to decipher. But overall, the risk of colitis or other side effects that you would theoretically worry about because you're also giving 5-FU-based regimen really has not been an issue.
Great. Well, thank you so much for that excellent presentation. So we just heard all of the practice-changing trials that have emerged in 2020 for metastatic disease. We're now going to transition to early stage 2-3 operable esophageal or gastroesophageal junction cancer. This really, we have not seen any significant breakthroughs in recent years, with a huge question mark over what to do in those patients that we give neoadjuvant chemoradiation to, followed by surgery, and who do not achieve a pathologic complete response. So this next study will be highlighting some of the practice-changing data that was presented at ESMO, also at that really important plenary session. By way of background, trimodality therapy, as we all know, is a widely used standard of care here in the US and around the world for patients with stage 2-3 disease. Unfortunately, however, the risk of recurrence following trimodality therapy remains high. We know that only 25 to 30% of our patients achieve a pathologic complete response. We all know that those patients who are lymph node positive do really quite poorly. We have never really had a prospective global trial to show us, number one, how poorly those patients do, and then number two, is there any additional novel therapy that we can add above chemotherapy and radiation to try to help prevent disease recurrence in our patients. Unfortunately, the addition of chemotherapy in the adjuvant setting hasn't been shown to be beneficial. A lot of the trials that we've looked at were poorly designed. They couldn't be finished. Patients were too frail after a big operation like an esophagectomy to complete the post-op treatment. But we did know that adjuvant immunotherapy, even before this year's ESMO, had efficacy in the metastatic setting. And so the reason for starting the Checkmate 577 study was, can we involve a novel therapy in the adjuvant setting that may give our patients some additional benefits? There's a lot of hypothesis about how radiation can alter the diversity of the T cell repertoire in intratumoral cells. We have seen numerous publications, there's numerous clinical trials looking at this. We know that radiation can really cause immature dendritic cells and antigen release to be primed. So you get a priming of the dendritic response, you get increased antigen release, you can get upregulation of PD-L1, and you can get upregulation of immunogenic cell surface markers. What we don't know is how long does that response last after radiation. No one has really been able to determine that as yet. A few years ago, I published a preclinical trial where we looked at an animal model where we created esophageal gastric anastomosis, where we bypassed the stomach, we brought the duodenum up to the esophagus, and we caused all of these animals to get esophageal cancer. And then what we decided to do was to give radiation to see if there was a change in PD-L1 expression and indeed other checkpoint inhibitors. The nice thing about this model is we could take serial biopsies from the rats via an endoscope. And we showed here that after radiation, just 16 gray of radiation, you can see here we got significant upregulation of PD-L1, which then did downtrend over a number of weeks. Of course, in our patients, we give 5 or 6 weeks of radiation, and so we don't know how long lasting that effect is. What we've seen in lung cancer world is in the durvalumab study, we show that those patients who started treatment with adjuvant durvalumab in inoperable stage 3 disease on the Pacific trial did better when they started their treatment earlier. However, those patients didn't need an operation. And in esophageal cancer, we still believe an operation is vitally important. But this is just some data that we've seen about the impact of radiation. And you can see here all of the different checkpoints actually go up. There's a massive release of interferon gamma, but a lot more work needs to go in to understand what is happening with radiation in esophageal gastric cancers. Having said that, the design of the Checkmate 577 study is here. This was a global phase 3 randomized double-blind placebo-controlled trial. The key eligibility criteria were patients had to have stage 2 or 3 esophageal cancer or gastroesophageal junction cancer. They can have had either adenocarcinoma or squamous cell carcinoma. All patients had to have neoadjuvant chemoradiation followed by a surgical resection. And all patients had to have residual pathologic disease greater than or equal to YPT1 or YPN1. So we excluded those 25 to 30% of patients with the best biology who have a pathologic complete response post-chemoradiation. So we really identified just those patients with the poorest biology to go on this study. Patients were stratified according to histology, pathologic lymph node status, and tumor cell PD-L1 expression. And in total, 794 patients were randomized across 165 centers in 27 countries, with 532 going on the nivolumab arm and 262 on placebo arm. And nivolumab was given 240 milligrams every 2 weeks for the first 16 weeks, and then we moved to once a month until the end of a year. So there was no more treatment after a year. The primary endpoint of this study was disease-free survival, and the data that we're going to show here is after a median follow-up of 24.4 months. Another important point to point out is we really don't have that many global studies in operable esophagogastric. If you look over the last couple of years, lots of practice-changing trials have come from the United Kingdom, from Holland, from Germany, or from Japan, but we've never really had a global study. So this is one of those first few that really enrolled geographical regions all across Europe, North America, Asia, and the rest of the world. Here's the baseline characteristics. You can see here the majority of patients had esophageal cancer at approximately 60%, with 40% having gastroesophageal junction cancer. Adenocarcinoma made up 70% of the patient population, with the rest being squamous cell carcinoma. And tumor cell PD-L1 expression occurred in 17% of patients in the nivolumab arm and 15% in the placebo, with the majority of patients not really having that tumor cell PD-L1 expression. This slide shows the median duration of treatment, and you can see here those on the nivolumab arm, 10.1 months, those on the placebo arm, 9 months. But the take-home message from this slide is this treatment was well tolerated. 89% of patients received nivolumab at a relative dose intensity of greater than or equal to 90%. The primary endpoint of the Checkmate 577 study was disease-free survival. And here you can see the Kaplan-Meier curves. Nivolumab provided a superior disease-free survival with a 31% reduction in the risk of recurrence or death, with a hazard ratio of 0.69, and a doubling in the median disease-free survival from 11 months to those patients on the placebo arm to 22.4 months on those on the nivolumab arm. You can see here, after a period of a few months, the curves separate and remain separate throughout the duration of the trial. I think the placebo arm here is very important for all of us, including all radiation oncologists, to understand that even after trimodality therapy and an R0 surgical resection, those patients of ours that do not achieve a pathologic complete response do very poorly. We've all known that from our own clinical experience with patients with lymph node positive disease. Unfortunately, you see them again in a few months and they've got metastatic disease. So here we can see it really, probably for the first time on a global trial, how poorly they do with a median disease-free survival of only 11 months. Again, we excluded the 25 to 30% who do very well. So these are that 70% who do poorly, and I think this is very important data for us to all be aware of. We saw benefit across multiple subgroups, and here you can see benefit was seen irrespective of histology for adenocarcinoma or squamous cell carcinoma, pathologic lymph node status, or even tumor cell PD-L1 expression. The take-home from this for my radiation oncology colleagues would be, we do not see PD-L1 expression having the same level of importance in this early stage disease trial compared to some of the trials that we've heard about in the metastatic setting. So we feel that patients can get this irrespective of PD-L1. What was the safety like? Well, overall, nivolumab was very well tolerated. The majority of treatment-related adverse events were either grade 1 or grade 2. You can see here those treatment-related adverse events occurring in greater than 10% were fatigue, diarrhea, pruritus, and rash, but the vast majority were less than that grade 3 or 4. So overall, very well tolerated. In terms of treatment-related adverse events with potential immunologic etiology. And what I would say here is when we were designing this study, we were a little worried about would there be pneumonitis in patients that have received thoracic radiation to the distal esophagus. I know we do exclude the lungs in all of those treatment plans, and Dr. Hales will talk about that, but that was a concern. What we were very glad to see was the rate of grade 3 to 4 treatment-related adverse events in the nivolumab arm was less, that was 0.8%. So we saw 4 cases of pneumonitis, and then dermatitis, grade 3 to 4, again, 0.8% each. When we compared that with those patients who just got placebo, we saw that 0.4% had pneumonitis. So really very low rates of pneumonitis, and I think that was a really important thing for this trial. One of the latter slides I'll show is the patient-reported outcome analysis. Here you can see, using 2 different models, the visual analog scale or the utility index, you could see the similar overall health status between those patients that were on nivolumab and those patients that were on placebo, which is important because I said at the start of this, patients really have not been able to tolerate adjuvant chemotherapy after trimodality therapy. So here we've shown this treatment does look to be safe. We did not see any new safety signals, and it's well tolerated by the vast majority of patients. This is a brief overview for your files in terms of what other trials are going on in early stage esophageal disease. Well, as you know, some people prefer to use perioperative chemotherapy and not use radiation alone. So there is trials looking at the use of PD-1 inhibitors plus chemotherapy. And you can see here all the other ones. There's a Attraction 5, which is looking at chemotherapy plus nivolumab. As I said, it's a little bit challenging to tolerate chemotherapy, so we'll have to see how these pan out. The question may arise is there a trial in the definitive chemoradiation section, area where we don't do surgery alone? The answer is yes. For those patients that get definitive radiation doses with chemo, we're combining those with checkpoint inhibitors to see if we can improve over the current standard of care. So a lot more work is going on, but I think what we're seeing now is a new era in the treatment of esophagogastric cancer, where we're going to be using checkpoint inhibitors more and more. And so it's important for radiation oncology colleagues to know about this. So when we discuss the optimal management at a tumor board, those discussions can be had. So the conclusion is nivolumab is the first adjuvant therapy to provide a statistically significant and a clinically meaningful improvement in disease-free survival versus placebo in resected esophageal and gastroesophageal junction cancer following neoadjuvant chemoradiation. I would point out that up to this point, only melanoma has been shown to be beneficial in the adjuvant setting. It's very unusual for gastroesophageal junction cancers and esophageal cancers to be leading the field in solid tumors with a new potential indication. So I think we're all very proud that this tumor type has been able to jump over other tumors that have been using checkpoint inhibitors in the metastatic setting for years. These promising results and ongoing research represent one of the first advances in years. In fact, we've never had any novel therapy to add in to early stage 2, 3 esophagogastric cancer. Everything we've tried has not been beneficial or has caused toxicity. We've only really had chemo, radiation, and surgery, and now we have immunotherapy that can be a new treatment paradigm for these patients. So we have a couple of audience questions. One question comes in is, how long after resection did you start the immune checkpoint inhibitor therapy? Well, that's a great question. When we initially designed this study, the study design had 4 to 12 weeks in the post-op setting to go on the trial. But a lot of investigators started asking us, my patient really wants to go on the trial. Can you just give them another couple of weeks to get over their esophagectomy? Which again, plays into why it's been so hard to do chemotherapy in this setting. So when we did a slight trial modification where we extended it from 12 weeks up to 16 weeks. So you'll see on the study design there, it's 4 to 16 weeks was the trial design for when people could go on. And then how did we define an R0 section? Well, this was on the surgical sample. There was no evidence of vital tumor within 1 millimeter of the proximal, distal, or circumferential margin. And again, that was discussed with numerous thoracic surgeons beforehand, and that was a widely accepted standard for an R0 resection. So I think now we'll come to one of the probably the most important part is how do we put this all together? How do we help everyone understand if these practice-changing trials will become standard of care in your clinics every day? So I'd love to introduce my friend and colleague from Johns Hopkins when I was there, Dr. Russell Hales, who's the chief of thoracic and esophageal radiation at Johns Hopkins and treated many patients on the Checkmate 577 study with me. So Dr. Hales, please.
Thank you so much, Dr. Kelly. It's great to share this time with you and with Dr. Janjigian. And happy to present a few cases that we can talk about. This will be our time to take the principles that have been discussed over the last 30 minutes and apply them to specific patients. And without further ado, here's our first patient. This is a 62-year-old who presented with difficulty swallowing and had an upper endoscopy that showed Barrett's esophagus from 30 to 35 centimeters from the incisors. There were no nodules present, but there was narrowing at 35 centimeters, and the gastroscope could not be advanced further. A malignant appearing, friable, and severely strictured area in the distal esophagus was seen, with biopsies showing invasive, poorly differentiated adenocarcinoma. There were separate fragments of squamous mucosa in the specimen. The patient underwent standard staging, including an endoscopic ultrasound, which showed ultrasound staged T3N1 disease with disease that extended into the adventitia and one suspicious periesophageal node. FDG PET, shown in this coronal view, showed marked FDG uptake in the distal esophagus with no evidence of metastatic disease. Additional CT of the chest and abdomen with IV contrast revealed no further sites of concern. So in summary, we have an otherwise healthy 62-year-old who has obstructive symptoms and a T3N1 M0 distal esophageal adenocarcinoma. For this patient, he was treated with concurrent weekly carboplatin and paclitaxel-based chemotherapy using the CROSS regimen. The radiation, however, was given to 50.4 gray in 28 fractions, followed by evaluation for resection. You can see the radiation plan in the bottom of the screen. Within a few weeks of starting radiation, he had improvement in swallowing, and although cytopenias prevented the last week of chemotherapy administration, he was able to finish the treatment without delay. Repeat PET scan showed a decrease in FDG uptake in the distal esophagus, consistent with a partial response to treatment with no distant areas of concern. And so this patient was then taken for an Ivor-Lewis esophagectomy at 8 weeks post-chemoradiation, with pathology showing 3 millimeters of residual adenocarcinoma within the muscularis propria, one periesophageal lymph node that had acellular mucin, presumably prior malignancy in that, consistent with treatment effect, and 14 additional nodes that had no malignancy, consistent with YP T2N0 disease to negative margins. So my question for each of you is, how would you proceed next in this patient who has undergone trimodality therapy? Dr. Janjigian?
Thank you for discussing this very important case. And I think, this is a very typical presentation of a patient that we see in clinic. Particularly what worries me about this patient is the signet ring cell histology, where, often these patients present at a more advanced stage than first thought. Before we talk about immunotherapy, I think what's also important to note, especially since I have the opportunity to discuss the chemotherapy backbone. For adenocarcinomas, CLGB 80803 study, which is the intergroup study supported by RTOG and other intergroup members of the NCI task force, really demonstrated that for adenocarcinoma, combination of 5-FU and oxaliplatin or capecitabine and oxaliplatin is the preferred backbone regimen. And so carboplatin paclitaxel, or the so-called CROSS regimen, is now considered relatively focused only on squamous cell cancers. And as you know, the initial Van Hagen data in New England Journal of Medicine looked at it in both adenocarcinomas and squamous cell cancers with chemoradiation and then followed by surgery. And so the important part about this patient is if you have a medical oncology colleague that is still giving, I understand this patient was treated a while back, but now in a modern regimen, if is still planning on giving carboplatin paclitaxel for adenocarcinoma patient, please ask them to reconsider and refer them to CLGB 80803 data, which has now been actually submitted for publication. Hopefully will be coming out soon. I think Ronan's presentation makes it very clear that for this patient, in the situation, radiation therapy and chemotherapy helped, but perhaps we can improve their chances of staying disease-free and potentially overall survival with addition of anti-PD-1 therapy. It would be helpful to know the anti-PD-1 the PD-L1 status of the tumor is, again, when you're considering the pros and cons, perhaps in a frailer patient and the patient who's less motivated to receive adjuvant nivolumab. I know that the 577 data was irrespective of PD-L1 status, but as I mentioned, having that knowledge may help you either convince the patient in a discussion or also prioritize adjuvant therapy.
Thanks so much. Tell us, when is the appropriate time to check PD-L1 expression, at diagnosis or at surgery after the patient's undergone trimodality therapy?
So typically, if you have a very good sample in a preoperative setting, in other words, at a diagnostic EGD, it's probably the best time because it's an untreated sample that's very good. Unfortunately, often if the patient was diagnosed elsewhere and then comes into a tertiary cancer center to try to receive therapy, there's issues with getting on stained slides and so on. So at any time point, if you have sufficient tissue, it would be fine. But ideally, it's the pretreatment before the radiation therapy.
Thanks, Dr. Kelly. Go ahead.
One of the challenges we have in some of those diagnostic EGDs is they take very little tissue. They take tiny amounts of tissue, and so we're going to have to start thinking about taking a little bit more at the time of doing a diagnostic EGD to help us. It's also a dynamic biomarker, right? So I tried to show there that radiation can cause PD-L1 expression to go up. But chemotherapy may do similar things in terms of changing the immune microenvironment. I agree with Dr. Janjigian. What we did in 577 is we tried to get the pre-treatment endoscopic biopsies, but that wasn't mandatory. But then we checked PD-L1 at the time of surgery. As I showed you, it does tend to trend down in animal models. We can't really do that in humans because you can't keep doing serial endoscopic biopsies when someone's getting radiation to see if it changes. So you just really have moments in time. So you can do that when the patient goes for surgery. But I think it's an important clinical case that you're showing here, Dr. Hales. It's something we see all the time. We haven't had great options. So historically, I think, and Dr. Janjigian would probably agree with me on this, we probably wouldn't have done anything else because there's no data for adjuvant chemotherapy. So if someone has had chemoradiation and surgery, and you would come back and say, okay, well, the lymph nodes are negative. I'm kind of a little bit concerned about the YPT2 status, but, I don't have any data, so we're just going to put them on close observation. We haven't had anything else. So that's, that's one of the reasons why 577 is an important study. It gives us other options.
Yeah, I agree. And operationally, just from practical standpoint, I know that some centers use fiducials for respiratory gating. And so when the patient is getting fiducial markers placed, just remind your endoscopists to get a couple of extra samples and just have them get into the habit of it. I think if we think about it and organize better, PD-L1 testing, it shouldn't be a barrier.
These are great insights, guys. I think the key take home is that for many of our patients, we would have stopped therapy at this point. There may have been a discussion about consolidative chemo with the signet ring features, as was pointed out, but now we have something additionally to offer these patients. Briefly to review the slides that were just presented, Checkmate 577 included patients who had upfront chemoradiation followed by resection. I just want to point out from a radiation oncologist view, the patients that would have been included, treatment with doses anywhere from 41.4 gray and 23 fractions to 50.4 gray and 28 fractions were acceptable for patients undergoing this treatment. Patients who had induction chemotherapy were not included. Again, the randomization of adjuvant nivolumab versus placebo showing a robust improvement in disease-free survival, as has already been shown. Just want to again point out the fact that although we focused on the importance of PD-L1 expression, that in fact the benefit was agnostic to PD-L1 expression in these patients. And so for our patient, the patient receives 16 weeks of nivolumab and continues on every 4-week nivolumab at this time. We just had a question or two that came in. One of them had to do with the medically inoperable patient treated with chemotherapy and radiation alone, and how we apply this data of Checkmate 577 to them. Dr. Kelly, your thoughts?
Yeah, so we did not include those patients. This was specifically to try to see if we could help those patients that get trimodality, where they were surgically operable, and to see if we could improve in the adjuvant space. Patients who had inoperable disease were not eligible. As I said, there is ongoing trials right now, so we'll just have to watch that space to see if the addition of a checkpoint inhibitor or a PD-1 inhibitor to chemoradiation, number one, is it safe? Are we going to get any toxicities that we haven't seen before? And then number two, does it improve on the current efficacy that we see with definitive chemo RT? The other group that we did exclude, Dr. Hales, were the cervical esophageals. We really did not include those. If there was any discussion about mid-level esophageal, mid-thoracic, should I say, they did discuss those with the medical monitor from the sponsor of the study. But the vast majority of patients were distal esophageal and then GE junction from Siewert 1, 2, and 3.
Thanks, Dr. Kelly. We're going to move on to the next case, but I want to give each of you a chance to give any other comments or insights before we talk about another case.
Well, I'll just come back to a point that Dr. Janjigian made about chemotherapy use. When we designed this study took a long time. These studies don't happen very quickly. What I will tell you, and we probably know this, metastatic studies are actually much easier to enroll on because the patients are very motivated to go on trials. When you do an adjuvant study like this, and someone's had, a couple of months of chemoradiation and then a big operation, and then you say you want to go on more for a year, they're like, some of them are like, what? Why do I want to do that for? So these are hard studies to enroll. This is why we haven't had great data in this space, because they're not easy. What we saw here was when the surgeon actually advised their patient to go on the study, because the surgeon was the first person really to see the patient and tell them about the pathologic response. And they usually would tell them a few days. They're probably still in the hospital. They did say, look, unfortunately, some of the lymph nodes came back positive, but we have a trial, we have an option. And I think that's probably what's going to play out in the real world setting too. It'll be people like you, Dr. Hales. Historically up to this point, all of the decision making has been in the realms of the medical oncologist. But now we've got a whole new group of people. That's why this conference today is so timely, because we all know esophageal gastric cancer is a multidisciplinary approach. None of us can do it on our own. So now educating the radiation doctors, educating the surgeons, because we're all in the same boat. How many times do our surgical colleagues go, "Oh, did you see the path report? I'm really disappointed." And then myself and Yelena may have said, "Yeah, but there's no real data for adjuvant chemo." At least now we have an option. I think that's an important thing that we can offer our patients.
Thanks, Dr. Kelly. Let's move on to the second case now. This is similar to the first case with some unique nuances that make it different. This is a 67-year-old who presented with a squamous cell tumor of the GE junction that was node positive and underwent chemoradiation followed by resection. But at the time of resection, the patient had adenosquamous disease, poorly differentiated, 6.3 centimeters of tumor remaining, with multiple positive nodes, 7 of 17. The margins were negative for this patient. And as a result, they were enrolled on Checkmate 577. This was one of the patients that was included, and underwent therapy on week 12. And except for fatigue and body aches, the patient really had no new symptoms and had 9 cycles of chemotherapy. After 9 weeks of immunotherapy, the patient presented with ground glass changes in the lung suggestive of pneumonitis. The patient was completely asymptomatic, though. Dr. Kelly, how would you proceed next with these radiographic findings in an asymptomatic patient?
Well, certainly, when we all have to be on the lookout for pneumonitis. Thankfully, on the study, we only saw 0.8% of grade 3/4 pneumonitis, but that doesn't mean everyone should be on the lookout for pneumonitis in any checkpoint inhibitor patient. So here, the optimal management is to certainly hold the treatment, and then you can discuss with the patient. We'd have to grade it, of course. You can discuss with the patient about, is there a need for steroids? Certainly, if they're symptomatic, you would certainly want to do that. So I think definitely holding the treatment here. You can't just presume, this is not drug related. I think that always has to be at the top of your list. And you always have to err on the side of caution. But it's good to show this because this can happen. Thankfully, very rare, but it's something for people to be aware of.
And Dr. Janjigian, would you start steroids in this patient?
Well, so I'm just looking at the images. It looks like it's bilateral, so it's not really within the field. I mean, the timing of this is a little early for radiation-induced pneumonitis, but you would also need to consider that. In a grade 1 case, which based on your description, he's asymptomatic, this was incidentally picked up. Obviously, you need to make sure to rule out other infectious causes and so on. But I would probably just monitor and not treat with steroids. It would be reasonable, I guess, to unblind the patient because it may help determine. But I wouldn't even go that far. I would just monitor. It's
great.
Most of these are self-limiting.
Most doctors now and pulmonologists know how to manage these. So I think discussing it at a multidisciplinary level, and if you need to get any additional workup, that would be the right thing to do.
Great. These are the very discussion points that we had as we considered how to manage this patient. These patients who have been through resection can have an increased risk of developing aspiration pneumonias. And so in addition to aspiration events, one also has to think about radiation-associated pneumonitis or checkpoint-related toxicities. And in this patient, given the bilateral nature that didn't easily encompass the radiation field, and given the fact that this wasn't a very classic aspiration picture, we felt it was most consistent with being related to the immune checkpoint inhibitor. Because the patient was asymptomatic, treatment was held, and 3 weeks later, there was partial resolution. You can see this image on the left in relation to the image on the right shows some improvement, but it wasn't complete improvement, and so the patient was discontinued from therapy altogether, and within 8 weeks had complete resolution of these changes. So this is just a reminder that in these patients, it's critical that we have appropriate and timely management of immune toxicities. And so involving a multidisciplinary team in doing this will be important. I just want to conclude with something key that you've heard throughout this meeting, which is the important nature of multidisciplinary care in patients like these, not only at diagnosis, but throughout the continuum of survivorship. Survivorship is increasingly involving maintenance therapy. This is improving the outcome for our patients and an exciting time to be treating them, but critical that we work together to develop and maintain best therapies in these patients. Dr. Kelly?
Thank you, Dr. Hales. So this really concludes our discussions today. I think what we've seen is front and center news that checkpoint inhibitors are here to stay now in esophagogastric. We've been watching on a little bit enviously from our colleagues with melanoma and lung cancer and bladder cancer. But now, as you can see, we have 2 very important trials in the metastatic setting and 1 very important trial in early stage setting, which really is a paradigm shift for how we're going to treat our patients moving forward. So I wanted to thank everyone for their time and their attention. Thank you very much for joining us, and we hope you have a great day.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GKC860.